Florence Nightingale is a name synonymous with compassion, rigor, and reform. The phrase "lady with the lamp" conjures a single luminous image: a woman walking the dim wards of a military hospital at night, checking the bandages and comfort of the injured. That image is true, but it is also incomplete. Nightingale's life is not only a story of tenderness, it is the story of method, measurement, and stubborn institutional change. Her work synthesized practical nursing, rigorous statistics, and politically purposeful advocacy. It reshaped the structures of care in Britain, rippled through empires, and seeded principles that underpin modern public health and health systems design. Florence Nightingale was born on May 12, 1820, in a city whose name she would carry through history. Her parents were members of England's upper classes. That position afforded her access to a private education rarely extended to women of the era. Her father believed in intellectual rigor and personally tutored Florence and her sister in mathematics, classical literature, modern languages, and philosophy. From these lessons emerged an early facility with numbers and logic, and with them a conscious orientation toward systems. The idea that problems are not simply moral failings, but structures in need of diagnosis and repair. Alongside intellectual cultivation ran a profound moral seriousness. At 17, she described an experience she framed as a divine calling. The content and tone of that calling changed over time, but its imprint did not. Rather than a sentimental piety that would produce private devotion, her sense of vocation translated into a discipline, a determination to direct intellect, organization, and resources toward alleviating human suffering. Social expectations in Victorian England assumed for women of her class a trajectory of domestic life and social marriage. Nursing at that time was associated with poverty, seaminess, and low social status. Yet Nightingale's conviction cut against those expectations. She refused to see the attention to the sick as a merely domestic virtue. She conceived it as a profession that required knowledge, training, and elevated standards of practice. Her first substantial training took place abroad. In the late 1840s, she traveled to Kaiserswerth, Germany, to study at a deaconess institution. There, she learned organizational discipline, hygiene, and a model of nursing built on systematized practices rather than ad hoc charity. The time in Kaiserswerth refined both her technical competence and her conviction that improved care required institutional change. Proper facilities, reliable supplies, trained staff, and above all, an expectation that nursing was a profession worthy of intellectual respect. When war broke out in 1853 between the Ottoman Empire, Britain, France, and Russia, it did not initially appear to be a stage for civilizing reform. The British military medical system was bureaucratic and under-resourced. Wounded soldiers were evacuated to hospitals whose ventilation was poor, whose sanitation was negligible, and whose supply chains were fragile. What was most alarming was not only that soldiers were dying, but that many were dying from preventable causes: cholera, dysentery, typhus, and infections that spread unchecked in overcrowded wards. Public reports and the testimony of frontline observers created an outcry in Britain. Under political pressure, Secretary of State for War Sidney Herbert requested that Florence Nightingale travel to the military hospital in Scutari, a suburb of Constantinople. She accepted. In October 1854, she led a team of 38 nurses to Scutari. This was an unprecedented move. It was rare for a woman of her social standing to take operational leadership within military medicine. What they found was catastrophic. barracks converted to hospitals were infested with filth. Bedding was damp and soiled, garbage accumulated, water supplies were unreliable. Basic medical supplies were scarce. Nursing care was minimal and unstructured. The mortality statistics were appalling. Reports from the period indicate mortality rates as high as 42% in some hospital wards prior to intervention. Over the succeeding months, the initiatives Nightingale and her team implemented: meticulous cleaning, improved ventilation, the establishment of laundries and kitchens, the organization of supply chains, and the training and discipline of nursing staff, produced a dramatic improvement in outcomes. Mortality rates dropped to approximately 2% in certain wards within 6 months of these reforms. Framed as a relative reduction, that change represents a decrease of about 40 percentage points from the earlier 42% figure, which equates to roughly a 95% reduction in mortality relative to the starting level. These figures are not the result of a single heroic act. They reflect methodical attention to multiple failure points within a system: contamination in water and bedding, the transmission of infection in poorly ventilated spaces, the absence of basic nutrition and cleanliness, and organizational chaos. Nightingale's approach combined managerial rigor with hands-on leadership. She instituted records, organized brigades of orderlies and laundresses, negotiated logistics with military officials, and insisted on routine. She also remained personally present, and her repeated nocturnal rounds gave rise to the enduring epithet, "Lady with the Lamp." That image served a strategic function as well. The lamp humanized the reformer and made the case for nursing's moral and practical value accessible to a public audience. Equally important was Nightingale's methodological use of data. She collected meticulous records on admissions, discharges, and deaths. She categorized causes of death and linked them to environmental conditions. The combination of qualitative observation, a ward that smelled of sewage, a patient with soaked bedding, and quantitative record-keeping made her case empirically persuasive. If authorities could not be convinced by moral appeals, they could be persuaded by systematic evidence. To render this evidence comprehensible to policymakers and the public, Nightingale innovated in data visualization. She adapted what she called the coxcomb diagram, a radial graphic that presented proportional causes of death across time. The coxcomb presented a vivid visual argument. The largest wedges of the chart corresponded to deaths from preventable disease, not from battle wounds. The clarity of the visual made it difficult for observers to ignore the primary drivers of mortality, and it reframed the debate from one of inevitable wartime suffering to one of preventable institutional failure. When Nightingale returned to England in 1856, she did not return as a private citizen, but as a national symbol. Newspapers celebrated her, and she met with Queen Victoria. Yet Nightingale herself was acutely aware of the difference between celebrity and change. Public honors were worthwhile for raising awareness. They were not an end point. She understood that durable improvement required institutional transformation, new nursing education, hospital redesign, professional standards, and legislative action. Nightingale's strategy combined scholarship with persuasion. She turned to writing. In 1859, she published Notes on Nursing, What It Is and What It Is Not. Though framed as a practical manual for household caregivers, the book was actually a manifesto for the principles that structured professional nursing. Attention to ventilation, sunlight, personal hygiene, sanitation of bedding, proper diet, and observational record-keeping. The plain language of the text made it accessible. while its insistence on method made it normative. In 1860, she founded the Nightingale Training School at St. Thomas's Hospital in London. The school institutionalized nursing education. It created a curriculum rooted in disciplined practice, ethical comportment, and managerial competence. Graduates were expected not only to provide bedside care, but to organize wards, supervise staff, and implement systems that reduced infection and improved recovery. The graduates of St. Thomas's disseminated these standards across Britain and overseas, as alumni established training schools and hospital reforms in India, Australia, and North America. Her reform agenda also targeted hospital design. Nightingale advocated the pavilion model, separate wards with abundant windows and cross-ventilation, physical separation of infectious cases, sanitary drainage, and the provision of light and air as therapeutic agents. These principles had practical benefits in reducing cross-infection, and they represented an early instance of design thinking applied to health outcomes. They anticipated later advances in infection control and hospital architecture, and they continue to inform the ways we conceive effective clinical space. Nightingale's use of statistics was more than instrumental. It inaugurated a new relationship between quantitative evidence and public policy. Her charts were not mere illustrations, they were arguments. They translated clinical realities into national priorities. Her coxcomb diagrams broke down mortality by cause and by month, making 2 points. First, they revealed that a majority of deaths were attributable to preventable conditions related to sanitation and logistics, rather than battlefield trauma. Second, by presenting these data visually, Nightingale lowered the cognitive effort required for policymakers to understand the problem and the solution. Visual argumentation accomplished what prose alone might not. It reduced deniability. Her engagement with statistical societies and her consultative work with military and civil authorities transformed public health into an evidence-driven enterprise. She argued that health outcomes were measurable and therefore accountable. When institutions accepted that mortality could be counted, compared, and reduced, the prospect of reform became politically viable. Nightingale's formal recognition followed. She became the first woman elected to the Royal Statistical Society and was later awarded Britain's highest civilian honor, the Order of Merit, in recognition of her contributions to public welfare. Those distinctions signified the societal shift she had catalyzed, the professionalization of care, and the legitimacy of women as authoritative voices in public administration and science. Nightingale's work extended beyond military hospitals and the wards of London. She viewed health as integrally related to environmental and social conditions. In Britain, her advocacy influenced the Public Health Acts of the 1860s, which addressed drainage, sewage, and clean water, core infrastructural elements that determine population health. In the British Empire, she advised on sanitary reforms in colonial hospitals and on nursing standards across the administrative apparatus. Her work in India illustrated both the reach and the complexity of her vision. She advocated for improvements in rural sanitation, better hospital design, and the training of local nursing staff. She was attentive to cultural contexts and practical constraints. Her aim was not to impose a single model, but to create adaptable standards that could reduce mortality and improve the sustainability of care systems in diverse environments. Nightingale's life after the Crimean War was marked by persistent ill health. She experienced chronic fatigue and pain, conditions attributed by many scholars to a post-war debilitation that might include brucellosis, a persistent infection, or other chronic syndromes. Despite these constraints, She remained prodigiously active in intellectual and policy spheres. Much of her later work was conducted from her home through letters and reports. Her output during these years was formidable. She supervised the Nightingale School, advised foreign governments, published reports on sanitation and hospital design, and continued to refine methods of statistical presentation. The scale of her productivity, despite limited mobility, is a testament to an organizational capacity that turned constraint into leverage. By cultivating correspondents, protégés, and institutional allies, she multiplied her reach. Nightingale's honors and her choice regarding burial speak to a complex relationship with public recognition. She was awarded the Royal Red Cross by Queen Victoria in 1883 and, as previously noted, the Order of Merit in 1907. When she died on August 13, 1910, at the age of 90, she declined an offer of burial in Westminster Abbey, choosing instead interment near her family home. The choice reflects a person whose public stature was matched by private preferences for modesty and rootedness. The practical consequences of Nightingale's work are visible every day. Nursing today is a regulated profession grounded in clinical education, evidence-based practice, and managerial responsibility. Training curricula owe a debt to Nightingale's insistence that nurses be not only compassionate caregivers, but also skilled practitioners and supervisors. Her emphasis on observation, documentation, and the maintenance of sanitary environments is embedded in modern standards of practice and accreditation. In addition, Nightingale's leadership offers lessons for contemporary health governance. She combined technical competence, bureaucratic navigation, persuasive communication, and moral clarity. She leveraged data not merely as numbers, but as narrative. She recognized the importance of cultivating allies across political lines. In an era when health systems face complex, multi-sectoral problems, from pandemic preparedness to antimicrobial resistance and the health impacts of climate change, her integrative approach remains instructive. Florence Nightingale's life teaches a simple but profound truth. Moral intention without method accomplishes little, and method without moral urgency is brittle. Her innovations in clinical practice, hospital design, training, and statistical communication combine to create durable change. Her life is the story of how evidence becomes policy when presented with clarity, how leadership grounded in compassion can be operationalized with systems thinking, and how one practitioner, armed with data and persistence, can alter institutions. Florence Nightingale's legacy reminds us that evidence, compassion, and structure together can save lives, and that progress depends on those who refuse to accept suffering as inevitable. Her light still burns, not in myth, but in every ward, every training program, and every data sheet designed to prevent needless loss. If this exploration deepened your understanding of Nightingale's impact and the birth of modern public health, consider supporting our work. Subscribe for more historical documentaries that uncover the people and ideas that shape the world we live in. Your engagement helps bring complex, evidence-based history to a wider audience and ensures that stories like this one are remembered not as legend, but as lessons. Thank you for watching. Until next time, keep seeking the light that knowledge brings.